Hello, I'm Dr. Yusuf, presenting to you this case of bilateral simultaneous cataract extraction with a weird complication that happened in the first eye, which was the left. I'm going to present first the right eye, just to see if you would notice the problem here, because I noticed it in the left side, so when I did the right side I was aware of it. So I'm starting my surgery as usual with the fixation ring and the 2.75 incision in the temporal part of the cornea.
Maybe some freezing inside.
Injecting the
bites a little bit that thing, okay?
xylocaine gel, preservative free with phenol 10% diluted to maintain dilation and freezing. Then I'm using the Indicoat to fill up the chamber, protecting the back of the cornea and the endothelium, and then covering the cornea, the front, with the viscoelastic, so you don't need to score the cornea throughout the surgery. I'm still using the fixation ring, and I'm opening the smaller incision, the 0.9 millimeter, 80 degrees foot to the left of the main incision. Now I'm doing the corneal marking, and this is very important for that. In this case, this mark will give you a 5.5 millimeter on the cornea, magnified to give you a 5 millimeter capsule Rhexis, and always follow that so to arrive at a 5 millimeter incision, 5 millimeter opening in the anterior capsule. So this way the capsule will be covering completely the optic of the intraocular lens, helping avoid capsule opacification and producing good centration of the lens. I'm doing the hydrodissection, hydrodelineation and recollortation at the same time. You can see the golden ring. I'm starting the phaco. I use the LenStar Signature Pro phacoemulsification. This is a nuclear cortical and posterior subcapsular cataract combined. I'm dividing the nucleus with chopping technique and removing the quadrants one by one. So the first half is gone. Now I'm working the second half. And removing the epinucleus while I'm protecting the capsule from being captured by the phaco tip. Now that there's nothing to protect it, I remove the chopper first, and then I remove the phaco. Now I'm using the J cannula, my design, the swan neck J cannula, to clean up the cortex. Always be careful to always be in the bag when you do this, and it cleans up the capsule very nicely without having to go after every piece to remove it with IA, which risks posterior capsule rupture. Now I'm inflating the bag and the chamber with Helon and the viscoelastic, preparing for a lens implantation. Here the lens is the Eyhance DIB00, and making sure it's going into the bag. And I'm not sure if you noticed that, but I'm not going to say what it is exactly. But in this eye, because I just did this first eye and had a complication related to that, so I noticed it and avoided it here. So I'm removing the viscoelastic from the anterior chamber, from in front of the lens and from behind the lens, but without going behind the lens, and just going in the front of the lens. And the Helon, because it's like the spaghetti, it just moves out, and then I'm going to use the irrigation cannula to clean up everything that's left, even behind the lens. So it's safer to do it that way. Then going with IA behind the lens, you can't risk capturing the capsule. I'm doing the wound hydration using the moxiflox as an antibiotic, and a lot of times I use the Dropless injection most of my cases. So
Look above your head. Look.
so this is the dropless injection. It's a mix of Thymoxy with some freezing. It's
done.
painless.
Wow.
It's frozen already. Patients feel nothing. Now I'm going to the left side, which was actually the first eye that I did. It's a denser cataract. But it has the same eye structure that caused the problem. So I'm starting the same way. This is real footage. I didn't edit time or anything, so it's all real time. So I opened the same steps, so the 2.75, 2 millimeter deep incision.
Look at the light. This
cornea.
is the freezing.
This is
Bites a little bit.
the freezing, the xylocaine gel,
Well.
xylocaine preservative free. Sorry, with phenol 10. This is the endopode going to the cornea from the front and the back. And then I'm using the fixation ring again to open the second incision, which is a 0.9 incision. It should be enough size to allow the chopper to go in and move freely. Now you notice that the ring wiped a little bit of the viscoelastic from in front of the cornea, so I'm gonna, this is the marking. Again, it's very important to do that marking. It helps you. I'm doing it routinely in every case to measure to give you 5 millimeter diameter. But now the viscoelastic is not very regular because of the ring removed part of it, so I'm just washing the cornea and putting another fresh coat of the viscoelastic to cover the cornea throughout the surgery. So I'm doing the capsule Rhexis to measure 5 millimeter in diameter. Most of the lens implants are 6.5 millimeter in diameter, the optic of it, and 12 millimeter haptic to haptic. So this will cover the optic of the lens. So, of course, the marks are not very visible on the cornea here, but it's very visible in the microscope. I just put a slight mark enough to be visible in the microscope. So the Rhexis is completed to be 5 millimeter in diameter, and then I'm going to go with the hydrosection, hydrodelineation, and nuclear rotation. It's very important to give a good hydrosection. This saves you a lot of trouble later. The hydrodelineation is also important. I like to leave the epinucleus till the end, so the hydrodelineation is very important to split the nucleus from the epinucleus, so it allows you to move the nucleus and leaving the epinucleus till the end. So I'll start with the phaco. This was the first eye. It was the harder lens a little, so it will take me a little longer than the first one to remove. Now I divided it. I do use the chopping technique, so I divided the nucleus into half and then thirds, and start removing the thirds, keeping the epinucleus till the end. And I always drag the segments into the center of the pupil to be away from the capsule, away from the iris, and away from the edge of the Rhexis. So the pupil plane center is the best location. It's the first away from cornea, away from the pupil, away from the edge of the Rhexis, and away from the posterior capsule. This is your safe zone, so always drag stuff and bring it into the center and then eat it up there. Now I'm dealing with the epinucleus. I like to keep it till the end. Sometimes it's pain to try to get it out. But here I'm using mostly irrigation, aspiration, rather than phaco. And always have the chopper move the things around and protect the capsule from being captured by the phaco tip. So the last piece of the epinucleus, so you notice the chopper is just behind the tip, holding away any capsule that might think of coming close to the tip. Now I'm done with that part. I'll go to my J cannula. So again, I made this J cannula to be narrow and to go through a small incision, like even 2mm incisions that will go through, by modifying how the tip looks. So it will result in a very clean capsule. Always make sure that your location is within the bag. Otherwise you can get into complication. And when you go coming out of the eye, you have to make sure that you're horizontal, exactly parallel to the wound, so that it doesn't capture the edge of the wound. Now I'm inflating the capsular bag with the heel on, and now I'm implanting the lens here. This is also the Eyhance DIB00. It usually passes through the wound with no problem, but here I had to do counter pressure to allow it to pass. So this injection was very nice, actually goes in smoothly. But see here, I want you to notice here that the size of the lens is actually big relative to the eye. The lens is normal size, but the eye itself is smaller. See that the lens is now displayed nasally. I'm trying to drag it back. There's no counter traction, so it wants to stay in this position. So I'm going to try to, I stopped immediately because when that happens, usually there's an open capsule. So you stop, inflate the chamber, just trying to test it to get it in the middle. Now it's centered, but it's not going to stay. I'm inflating the eye, and you notice it's no move back into the nasal position. So now I know it's for sure there's a problem. So I'm going with the heel on to try to reposition the lens to make sure it stays in a good position. Now the lens is in the bag, and probably there's almost 100% there's an open capsule on the nasal part of the bag. So I didn't see it yet, but I assume it's there. So what I did, I actually moved the optic, the edge of the optic, to be above the capsule, and that's why I said it's very, very important to keep the capsule Rhexis a good size, so that when you are in trouble, that will save you. So this way, I kept the haptics in the back, the optic is in front of the back, and held in place very, very nicely. Very important not to do any suction at this stage. If you guys have an open capsule, you can drag some vitreous, and it's very stable. The lens stayed in that position. I saw her after the surgery, staying very stable. Probably she's gonna need capsulotomy later, because now we have the anterior and posterior capsule are touching with no barrier in the areas where the optic is in front of the back. So this way, it's going to be stable.
I'm almost done with just putting
course,
the antibiotic on, that's it.
For years to come. I'm hydrating the wound with my usual moxifloxacin antibiotic, filling the chamber with that, making sure it's stable. You can notice that the lens is going nowhere. It's very stable, tucked very, very nicely. I'm hydrating, making sure that there's no low pressure here. You don't want to have low pressure, because otherwise it's going to come out. You have to keep it average, not too inflated, not too low. And this is my Dropless injection, Trimoxy. And you notice it's painless, completed, patient didn't move.
Good.
And that's it for that. But why did this complication happen? So if you looked at the literature and reviewed her chart again, I found that her eyes are small. It's her corneal size is very small. You notice that this is a 13mm ring, and it's much bigger than the cornea. So, and when I implant the lens, you notice that the lens is really big compared to the size of the eye. So her white was 10.4, and the average is 12.4 or so. So it's the size of that thing, and when I implanted it the regular way, it probably has pushed into the nasal capsule and opened it when I was implanting, and that's what was the problem is. So The take-home message is that you have to always keep an eye on the white-to-white diameter. Even though the eye doesn't look small, she's an average lens implant, like 22 power, so it's not a very high power that will get you to think it's small. But this is a micro-cornea of 10.39 to be exact on the IOL-Master, and the average in my community is about 12.5 approximately. And recent study by Bobby Osher and Dr. Chin, they found that the average cornea is about 12.4 approximately, and any cornea less than 11 is considered to be microcornea. Above 13.2 is considered to be macrocornea, and you have to take that into consideration. Now, when I review any surgery, before the surgery, I look at the lens power, review the lens power, make sure that the plan is okay. And now I started looking at the white-to-white to know what size of an eye is it, so that when I do the surgery at this stage, I will look at it. And this is where the white-to-white is visible on the LenStar. Here you can see it highlighted in red. So microcornea. This was the first normal patient, and this is my patient. This one was 10.39 millimeter, and that's why I ended up with this complication. And this is the Bobby Osher and Chin study that showed this to be a problem in certain communities, and this is the average is 12.12 or 12.22. Thank you for listening.